Hello, everybody. Nelson Virgil here with a program for wellness restoration. This is a video that belongs to a series of educational videos we do at powerusa.org to educate the community and clinicians about new approaches, not only to HIV treatment, but also in cure research, in side effect management, et cetera, et cetera. And I'm very honored today to have Dr. Vincent Marconi. I'm going to tell you about his background really soon, but he's doing very exciting research on a new type of drugs that are already approved for other uses, not for HIV, but they're exploring this type of drugs called JAK inhibitors for not only seeing if they can decrease inflammation in HIV or decrease the amount of HIV in the reservoirs, or treat HIV with hopefully low side effect profile. So we're very excited. It's a new approach. There are drugs that are already being proven to work in other diseases. We have enough data to at least say they're kind of safe. And I'm very excited. Dr. Vincent Marconi, thank you so much for joining us. He received his MD at Johns Hopkins School of Medicine in 2000. He then received training in internal medicine and infectious diseases at the Brigham and Women's Hospital at the Massachusetts General Hospital of Harvard. Currently, he's a professor of medicine for the Division of Infectious Diseases and professor of global health at the Rollins School of Public Health. In 2014, he became the director of infectious diseases research at the Atlanta Veterans Administration Affairs Medical Center. Dr. Marconi sees patients in both the infectious disease program, Ponce Clinic, part of the Grady Health System in Atlanta, as well as the infectious disease clinic of the Atlanta VA Medical Center. He has co-authored over 90 scientific articles, and we're very honored to have somebody with such a great background and great interest in doing research in HIV to explain to us what his study is all about and how to enroll and how to actually get to participate in this study. So thank you so much for joining us, Dr. Marconi. How are you doing?
Thank you. I'm doing very well, Nelson. It's a real privilege and an honor for me to be a part of your program. I'm a huge fan, both of your program and of your followers. So we really appreciate, again, the opportunity to speak with you all. Yeah, so just briefly, in addition to what you mentioned, I'm also an investigator of the AIDS Clinical Trials Group. That's the ACTG Network clinical research site here, as you mentioned, Emory University in Atlanta. And, as you are familiar with, the ACTG Network is the largest AIDS clinical trials organization in the world. It's funded by the U.S. Department of Health and Human Services, which is the National Institutes of Health, National Institute of Allergy and Infectious Diseases, and the Division of AIDS. And it's participating sites around not just the U.S., but around the world. I really got involved with this work, and it is very exciting. And I think this is a time now in HIV research to pivot from, trying to get patients virologically suppressed and out of AIDS-defining illnesses, but to sort of move into a new realm of improving health and well-being for patients. So really the focus of my research in general is to identify the underlying biological and socioeconomic conditions which lead to differences in outcome for HIV-positive individuals in both domestic and also in international settings. So really the overarching goals of my work are to enhance the HIV care continuum as well as decrease age-related diseases by reducing inflammation and also limiting the HIV reservoir. And this has really been exhibited by my desire to develop and launch ACTG A5336. And the title of that study is a randomized pilot study of Ruxolitinib in antiretroviral treated HIV-infected adults.
Can you say the name of the drug again very slowly?
Absolutely.
Are impaired with my Spanish accent,
Without a doubt, it is a mouthful. It's Ruxolitinib.
And there is a brand name, right, to the drug is already approved, right?
That's right. It's known as Jakafi. Insight, who's registered the drug, has named it Jakafi.
And what's a drug approved for right now?
Yeah, so currently, just to give a little bit of background on ruxolitinib, as you mentioned, it is a JAK-STAT inhibitor, and, just a word or two on what that means. So JAK actually stands for Janus kinase, and it's an enzyme that's involved in specific cellular function. So patients with overactive JAK pathway signaling have an increase in inflammation-related diseases. So ruxolitinib, as you mentioned, has been FDA approved for myelofibrosis. Now, that's a disease where the bone marrow is heavily scarred and not working properly. It's also approved for polycythemia vera, and now that's a disease where too many red blood cells and other cell types are made. So, as it's been shown in many clinical trials with ruxolitinib, that there's dramatic reductions in key biomarkers of inflammation for these now HIV-negative individuals having either myelofibrosis or polycythemia, and it's even being explored in other diseases.
Oh, great. So how did anybody, I interviewed maybe 4 years ago, Dr. Chinetzi, hopefully I'm pronouncing his name well, about this, because I saw a poster presentation at a conference in Europe where his team mentioned the fact that these drugs can actually control HIV replication at very low doses when we compare the doses that are used for the approved indication. And obviously, as I'm a salvage patient, I'm a patient, HIV positive patient for 30 some years, and I have multi-drug resistance. So I'm always looking for the next thing that could work in people like me that have been running out of options. And that's when I made my first contact with Dr. Chinetzi, and we had an interview, a very good interview on thebody.com that was published. We will be showing the link to that interview in the body of this transcription that we're going to make for this interview. So how did this whole thing start? When you got approached to research the drug for HIV, can you tell us that story if you can?
Yeah, absolutely. So, as I'd mentioned, really now we're trying to identify ways that we can reduce inflammation. As you know, inflammation is sort of the key driver for these what are called age-related comorbidities and diseases. So things like cardiovascular disease, strokes, cancers, frailty, bone disease, all of these appear to be driven primarily through an inflammatory state. And so we're constantly trying to identify, these new proof of concept opportunities where we can study compounds that typically are already being used in non-HIV populations to identify if these can actually be safe, tolerable, and decrease the sort of harmful inflammation and hopefully lead to a decrease also in the HIV reservoir. Because as you know, not only does this inflammation lead to these sort of bad outcomes and diseases and conditions, but it also tends to keep the HIV reservoir perpetuating over time. So it sort of keeps cells replicating that may harbor the virus. It also increases target cells where HIV can enter through that inflammatory process. So Dr. Shinazi, who's aware of the program that has been started with our group and also working with the ACTG, really we approached each other, interestingly enough, about his research that had been going on, looking at both in vitro as well as animal models, where ruxolitinib, having been identified to reduce inflammation in these other populations that I mentioned, were actually shown to have an antiviral effect on HIV as well, again, in these in vitro and animal models. They also found that it seems to prevent reactivation during that process. So it turns out it won't wake up the cells and cause them to replicate, but does over time appear to decrease the reservoir, mainly because of this concept of allowing the cells to no longer proliferate that have HIV in a quiescent state. So we talked about, how we could structure a study like this particular study we have now, and other studies in the future with similar compounds where we could explore reducing inflammation in a safe and tolerable way, and overall, in time, be able to decrease these age-related comorbidities as we discussed.
Good. So about the study, tell us a little bit about what the study is about, what kind of patients you're looking for, what kind of patients you are not looking for, and how can somebody actually contact any of the study sites to enroll, etc. And we'll go into side effects later or what to expect.
Absolutely. So, as I mentioned, this study is really a series amongst many of really first proof of concept safety and tolerability phase 2 studies looking at these novel drugs to decrease harmful inflammation, and as I mentioned, combat persistent HIV infection in the reservoir. And so, what we're looking for in terms of inclusion criteria are individuals who are HIV positive, either men or women, between the ages of 85 and 75 years of age, with CD4 T cell counts greater than 350 cells per microliter. And again, that doesn't...
85 to 75?
75.
And what's the lower side of that range?
18.
Okay, you said 85. I was like, wow.
Oh, sorry.
18, okay.
Yeah, 18 and 75.
Very hard to enroll, even for the old folks like me.
Yes.
18 to 75?
18 to 75.
All right,
That's
good.
right.
We're good. Okay.
So again, as I mentioned, really we're looking for individuals whose current CD4 count is above 350. So it's okay if you had previously been below that range. We're not looking at a nadir above a certain level, but if you're currently above 350 cells per microliter. And again, patients have to be currently experiencing virologic suppression on continuous antiretroviral treatment for at least 2 years. And that is containing either a non-nucleoside reverse transcriptase inhibitor, such as efavirenz, for example, or an integrase strand transfer inhibitor without cobicistat. So, for example, couldn't include elvitegravir with cobicistat, but could include dolutegravir or raltegravir, for example. And really no other major medical conditions or any prohibited concomitant medications. Again, we're trying to look at this within a relatively healthy population to ensure that the medication is going to be safe and tolerable for those individuals.
How about exclusion criteria? Who should not be applying for this study?
Yeah, really, we want to, again, not explore this drug at this point with individuals who are experiencing ongoing significant medical conditions, people whose virus is still not suppressed. As I mentioned, if your CD4 count is too low, if you're being treated for a significant medical condition, those individuals who may have some degree of mental health conditions that are requiring lots of follow-up and therapy at this time, we really, again, want to make sure that this is going to be safe within a safe population first, and then over time we'll be able to study this in a broader HIV-positive population.
How about any history of cancers, malignancies, herpes?
Yeah, at this time we need to actually exclude patients who have histories of cancer, again, because there's a chance that there could be changes or significant side effects that may affect that population, wherein we want to make sure that it's safe first for the healthiest patients.
And how long is the study? And the drug is oral, right? Taken twice a day?
It's an oral medication given twice a day, and this is actually at really the lowest dose that's given in standard sort of medical environments. So it's going to be 10 milligrams twice a day, and if you're on the treatment arm that's receiving the ruxolitinib, it's only for 5 weeks that you'll be taking it. So from day 0 until completing 5 weeks, and then we'll follow you afterwards for 7 weeks just to make sure that there's no other side effects or anything else that happens after that, as well as we'll be able to follow these markers of inflammation and the reservoir through that period of time. Now, if you're randomized to the no treatment arm, you will continue, both arms will continue with their antiretroviral treatment, but there will be no placebo. You'll just be followed through the entire 12 weeks to, again, make sure that we have comparisons in terms of side effects and other medical conditions that may arise during that period.
And what are the side effects that we have seen in other conditions where maybe higher doses are used? Where are they?
Yeah, that's right. So really most of the side effects that have been seen in the registration trials were a function of the significant underlying myelofibrosis, as I mentioned, or the polycythemia vera, whereby There were reductions in some of the blood counts, especially at, as you mentioned, the higher doses and for prolonged exposure. So really, these were individuals who were taking up to 25 milligrams twice a day or 50 milligrams twice a day. They did see often transient declines in their red blood cell count or their platelets. That's the cell particles that help your blood clot. Those would go down. They typically resolved after about 8 to 12 weeks. And again, these were individuals whose bone marrow were already suppressed or already having problems. And so the medication caused some changes there. But then as the disease became treated because of the ruxolitinib, they saw a resolution in those side effects.
Okay, and that's good. But for the patient that has to come in, how many visits and how frequently are they?
Yeah, so for the total of the 12 weeks, the first week and the fourth week, there's going to be an extra study visit that's required because we're wanting to make sure that there's not going to be any effects of drug-drug interactions with the HIV medicines. So there will be a visit whereby we'll need to take some blood in the morning, and then after you take the medication, we'll take another sample of blood later in the afternoon. So that occurs, that sort of pharmacokinetic, as it's called, sampling happens in the first week and again in the fourth week. But otherwise, there'll be set study visits that occur within that period of 5 weeks on treatment. And then we'll have a follow-up visit that happens again at weeks 10 and 12 at the completion of the study visit to make sure that we have all of those markers accurately measured for any variability that can typically happen within a week's period of time. So that's why there's a couple of visits at the beginning and a couple of visits at the end to ensure that any changes that we see with respect to these inflammatory markers are real changes and are not just variability that you could see on a day-to-day basis.
And how many patients are you looking for, and how many research centers are there in the United States?
Thanks. Yeah, that's a great question. So we're looking for 60 in total. There'll be 40 individuals who will be randomized to the ruxolitinib, and the other 20 are going to remain on their antiretrovirals without placebo, but just followed as sort of an open label mechanism. Currently, we're open to enrollment at our ACDG network clinical research sites here in Atlanta, as I mentioned, Birmingham, Cleveland, Ohio, Houston, Philadelphia, Los Angeles, San Francisco, Aurora, Colorado, Seattle, Washington, Nashville, Tennessee, St. Louis, Missouri, New York, and recently just opened at Vanderbilt in Nashville, Tennessee. And there's several other sites. We're expecting probably over the next few weeks, another 10 additional sites will open up. So we really expect most major cities around the U.S. that have ACG network sites will be open and ready to take patients. Again, we're expecting over the next couple of weeks. So really, if you want more information about ACDG A5336, including the contact information for potential study participants, please, we encourage you to visit www.acdgnetwork.org and click on the trials open to enrollment. There, you'll find all the information that you need regarding the study and if you have any additional questions.
Yeah, I will also be including a link in the transcription of this interview, and also below, because this will be on YouTube, and below on the description of the video itself, so that people can click on the link and actually get to the places they need to go. Let's talk about altruism versus expectations, because I'm a treatment activist, and we always walk a very fine line when we're trying to encourage research in HIV. We're trying to tell people, hey, we need to enroll and we need to get into these studies, otherwise we're never going to get to a cure, we're never going to get to finding out more and more about this virus. And at the same time, we're saying, well, but hold off, these are the expectations. Don't join this study because you think you're going to get cured, or you're going to get your whatever benefits you think you are. This is a purely altruistic thing to do, because there really are not real expected benefits. They're hypothetical benefits, maybe, of joining the study, but not real proven benefits. So can you I know this is a little bit of a ethics discussion, which can be lengthy if we get into it, but can you talk a little bit about that? Expectations versus just the fact that this is an important question to answer.
Yeah, no, you know, this is a really fantastic question that you're posing, and I think it is one that deserves some attention. I'll say that, you know, throughout my career, both in medicine and in HIV, we've largely been driven by what our patients want. And at the end of the day, you know, if patients are asking for additional or new directions to help them, that their life isn't completely fulfilled, that they're experiencing still some adverse effects of medications, or they're finding that they are, as we know, is still having a reduced ultimate survival and experiencing some of these conditions that people without HIV don't experience, then that means we do need to do something. And I'll give you just a brief anecdote. A patient of mine, you know, without giving names or any identifiers, he's between, we'll say, 20 and 35 years old. He's had the disease for over a decade now, and he's looking at, hopefully, we're anticipating another 50 so years, living a full and robust life. And he unfortunately has suffered many complications because of the early years that he went without treatment, complications from AIDS that have left him physically impaired and his senses impaired. And his life is very challenged as a result of it, but he's a fighter. He's a strong person who's committed to living, the best life that he can. And for many individuals, that seems like a long period of time. I would imagine being on these medications for 50 years is a very long period of time, and with the expectation that there's more things that he's likely going to experience because of HIV and because of potentially side effects of the medications. So he urged me, and I'll urge those who are listening, that we do need to do more. We have accomplished a tremendous amount over the last 20 to 30 years of HIV, both activism, pharmaceutical development, clinical research, and community involvement. But I think this is an area where we're at the edge of the envelope now, and we need to push to the next level. And for those who are participating in this, whether you're a community member, whether you're a participant in the trial, whether you're a site leader or a provider, this is what we need in terms of the next steps. We need to understand how we can reduce inflammation, how we can make quality of life improved, and how we can extend survival, because we're not yet there. We know that there's still a gap, even for individuals whose CD4 counts get above 500, there still is a gap between folks with HIV and without HIV in terms of survival. So although you're right, there may not be, and we don't anticipate any direct benefits as a result of this trial, we do expect to find some further insights into how we can reduce inflammation, how we can work towards a cure, and how we can make lives better for people living with HIV.
Good. So when it comes to inflammation, what are you going to measure to see if, whether or not this drug actually decreases inflammation without causing, obviously, side effects? And obviously, it's a very short study of exposure, 5 weeks, you said?
That's right.
Really, obviously, even if it was to have great benefits when it came to quality of life or whatever, or even pain, body pain. A lot of us have a lot of aches and pains. Some of us have high CPK, and there's still a controversial discussion whether or not drugs, some HIV medications increase CPK beyond, obviously the statins that some people take. There's some of us also, and I answer questions on the body on aging and HIV. That's one of my columns. And I'm also on aging. I'm 58 years old and with HIV for 33 years. And I do hear from a lot of people that are complaining about, I think my mother, who is 30 years, 25 years older than me, is doing better than me when it comes to, aches and pains. In my case, that's true. And they say, is this what a 50-year-old or a 60-year-old person should feel like? Because we're experiencing a lot of inflammatory related issues. In my case, and this is my personal anecdote on why I'm so interested in inflammation and JAK inhibitors. It's, I've been diagnosed with IBS, inflammatory bowel disease, and some of us are too without being diagnosed. Many people with HIV, when we get together, the first thing we talk about is our gut function, our GI, like old people. So I'm very interested in seeing what can decrease this inflammation that we seem to have even after years of successful undetectable viral load, and how our outcomes may actually be improved when it comes to all this. So for me, this is a very exciting area. That's why I decided to have this interview with you, because this goes beyond what we've seen before of not only looking at the reservoir, but looking at inflammations, and hopefully also at HIV viral load. So you're measuring inflammatory markers, and what else are you measuring, and what inflammatory markers?
Yeah, so the primary endpoint, in addition to tolerability and side effects and things, and as well as I mentioned, the drug levels, is IL-6. So as you, I know, are aware, IL-6 has really, resoundingly had multiple studies showing this to be the primary predictor, correlate, and likely causal agent, at least somewhere in the pathway, for both inflammatory-related diseases that we've mentioned, these age-related comorbidities, as well as in survival. I mean, just hands down over all of the other biomarkers, this seems to be the most predictive and most highly correlated. So that's going to be the primary endpoint, but secondary endpoints will include other things such as D-dimer and high-res C-reactive protein. There's multiple others, tumor necrosis factor that we'll be looking at, other interleukins in addition to interleukin-6. And we'll also be looking at markers of inflammation on the cells. So there are certain markers that, in addition to being in the plasma, you can find on the inflammatory cells themselves. So these markers like CD38 and the HLA-DR are going to be looked at, as well as a monocyte populations as well. So you're looking at CD14 and 16 markers, CD163. These are the ones on the sort of monocyte macrophage lineage cells that are also involved more in the innate immune system as opposed to the adaptive immune system. So a really large panel of biomarkers we're going to be looking at. In addition, we'll be doing some, as you call, profiling that can look at gene transcription. So we'll be able to see across the genome whether there are other markers of inflammation that are being expressed high or low in these two groups, to see if ruxolitinib can have an impact in an even broader range than just the standard markers that are explored.
Yeah, and this is a question that I just came up with right now. You know, when we talk, we always come up with things.
Absolutely. So
we do have some data on inflammation in other pathologies where these drugs are being used, right?
Yes.
Data, right? And we actually have, do we have data on IL-6 in other pathologies using this drug at all?
Absolutely, and probably didn't emphasize this enough towards the beginning, but in myelofibrosis, there were dramatic reductions in IL-6. In fact, IL-6 was the major marker that seemed to decline with ruxolitinib, both in the myelofibrosis populations as well as in polycythemia vera. And that was what struck us most, because this is the one we're going after. This is the one we're most concerned about in HIV. And lo and behold, this drug seemed to be acting most prominently on IL-6, in addition to tumor necrosis factor, CRP, and the other ones I mentioned. But the largest reduction in the New England Journal of Medicine papers that were shown were in IL-6. So we felt very confident that that's the marker that seems to be implicated most prominently in HIV population. So that fit really well with what we were going after.
Yeah, and I've seen data, IL-6 and D-dimer have also been linked or correlated, I don't know what verb to use in this case, to cardiovascular disease and events in HIV also, right? So hopefully if this works eventually in phase 3 and beyond, we can hopefully see some reductions in different things, including cardiovascular and other inflammatory related issues. Let's talk a little bit about, quality of life. So are you going to measure at all? You're going to find out how these people are feeling through the study, or are you going to be tabulating that in some form or fashion?
Absolutely. So sort of at each clinical research study visit, we're going to administer a real detailed symptom assessment, including, as you had mentioned, so GI symptoms, for example, with IBD. There's going to be a significant symptom assessment score that we're going to measure both a couple of times before entry, what we consider the baseline period, and then all the way through the study and after discontinuation of the medication, to see were there any changes, any signal at all in those various symptoms, because we do want to capture not just what's going on at the molecular or the biological level, but we want to see how people are feeling. So, we do want to make sure we are interested. I think this is a great point you raise regarding GI symptoms. We want to see, really, are there things such as even loose stools or bloating that people might not traditionally offer, or they've gotten so used to it, they may not report it on these questionnaires, but we really want to instruct our interviewers to probe for these symptoms and see, are there changes in either group, in the group that's given ruxolitinib and the group that doesn't receive it. So yeah, that's a major part of the analysis.
Good. I'm very glad to hear. Even a simple question as, have you heard this morning when you woke up? Because that really is when we all talk about it. It's, God, I wake up and, I'm all sore and it's like somebody beat me up. Yeah. And that's all inflammatory related. One more thing, because it's another ethics discussion, because we have a lot of these discussions in our meetings, is women. The enrollment of women. Obviously, most HIV studies don't have enough women. And people are always discussing, we've been discussing that for 30 years. 30 years. There's some studies that have been obviously more successful than others. So as a community, we're all saying, well, women are really busy. Women are taking care of people. They're caregivers. They usually have to take care of several people before they can take care of themselves. So studies that provide incentive, that's not the right word, facilitate their enrollment. Do you guys have anything for women with children, for instance, any either transportation assistance or even childcare assistance? I'm sorry to hit you with a new question.
That's a really great question, Nelson. I appreciate you asking that. So, all patients are uniformly compensated for their time. Like I mentioned, there's going to be some aspects of the study where they'll have to come back even on the same day, and they'll get appropriately compensated for that time. I'm not aware of any specific additional amounts that are provided for childcare. I do know in our clinic and other clinics around the country, we do have specified childcare that is available for patients and participants in the clinic that they can bring their kids by. We also do have transportation assistance that's available for individuals that come. And again, that would be unique to the clinic where patients are seen. But that's something absolutely we can discuss with our ACTG funding institutions and find out if there could be additional compensation that's made available, because you're right, there is an area where I think we're all struggling to reach out more to women, especially in the clinics I work in here. As I mentioned, the Ponce clinic, we have about 25% of our patients are women, and it's one of the largest clinics in the country, both overall and that see women. So we're very much attuned to this and do want to do more than we're already doing to help both on the patient side as well as in participation in research studies.
Good. I'm glad to hear. Well, I guess, do you have anything else to add before we wrap up? As I said, we're going to be posting this video on YouTube, hopefully on thebody.com, other sites with a transcription. We're going to be posting how to contact the sites, etc. But do you have anything else to add before we all say goodbye? And people may be asking questions afterwards. Usually on YouTube, you have sections at the bottom where you can post questions, and I may in the future forward some of these questions to you after people watch the video. So anything to add before we depart?
Well, just, thanks again so much, Nelson, to you and to your viewers. It's really a tremendous honor to be able to speak on this forum and as well to talk about our study. Again, I'll open the lines of communication for me directly or through you. I'm happy to answer any questions either about this study or other studies that we're involved in here and elsewhere at the ACTG and our sites here in Atlanta. You know, I really think we're very excited about this study and about others that we're currently in development. Ruxolitinib, it would be, if this turns out to be all that we're hoping and intending, would ideally be safe and tolerable and significantly reduce the inflammation and HIV reservoir that we're hoping for without any substantial effect on, you know, antiretroviral levels at this point. Would really be a first-in-class agent to do this. And I think this is important because we now know that we need to impact survival and quality of life more than we already have done. There's been a tremendous amount that's done. But as you stated, as we're aging, as we're getting older, we should see these side effects and we should see these symptoms be ameliorated over time. And we have to continue to push the envelope to do that. So this shows promise, and there are many other in the pipeline right now, so please stay tuned. And again, thank you very much for your time.
Thank you so much, Dr. Marconi, and I appreciate your time. We can probably one day talk about other studies because I'm sure you have a few of them, so we can bring you back. You've been a great speaker, and I want to thank everybody watching this video. For more information, also visit powerusa.org, thebuddy.com, and other resources that I'll be posting down below on the video description. So thank you so much. Thanks again. Hopefully we'll see you again, and good luck with the enrollment of the study. I hope people really call and get involved. It's only 60 people that you're looking for. That should not be too hard with so many centers. So good luck and thanks again.